So I've been dispatched to a 70-year-old male complaining of central crushing chest pain and syncope and dizziness. He has a previous medical history of an MI 5 years ago, however he states that tonight's chest pain feels different. The patient is presenting to me as pale and clammy. He's a responsive voice but he's unable to obey commands. I'm placing him on the GCS of 10. He's also got palpitations in his neck and he's on medications of cilateral aspirin. We've taken a set of vital obs already and his heart rate is at 170 beats per minute. He has a BP of 70/40, a respirate of 18, a BGL of 7.6 and a temperature of 37. After reviewing his 12 lead, I decided to call for an R50 status 1 backup. I've assessed his level of compromise as being unconscious VT from cardiovascular compromise. I did have a differential diagnosis of the patient having supraventricular tachycardia with aberrancy. However, after reviewing the 12 lead, I've ruled this out. So due to the patient's level of consciousness, I wish to sedate him before commencing cardioversion. To do this, I'll be using the drug ketamine, which I'll be calling clinical desk for assistance in administering and guidance. Ketamine comes in an ampule of 200 mg per 2 ml. I'll be withdrawing 100 mg, which will be 1 ml, and I'll be diluting it in 9 ml of saline to create 100 mg per 10 ml solution. Before administering, I'll also apply a medication sticker and a drug check with my crew partner alongside the saline, which I'll use to flush following administration of the ketamine. Ketamine you administer 0.5 mg per kg, and seeing as the patient is approximately 70 kilograms, I'll be administering 35 milligrams, which will be 3.5 milliliters. So currently my patient is being oxygenated at a rate of 15 litres per minute. I've also got my bag valve mask here on standby in case of need for manual ventilation. I'll have my crew partner monitoring the patient's vital signs, particularly their SpO2 levels, their rate of breathing and their level of consciousness. And in case I need, I'll also just reassess the patient's level of consciousness. If they're not sedated, I've got the remainder of my ketamine on standby to sedate them. So now we are ready to start cardioverting the patient, so we'll be consulting the cardioversion checklist in the pocket CPGs. First off, we make sure that all the pads are in the correct locations, which they are. Then we ensure that the defibrillator is in manual mode, which it is, and I've already selected a lead with the most visible R wave, and the artifact is minimal. Now we select a synchronized mode and wait for an indicator to appear above every QRS complex. Okay, now that's ready. Now we've ensured the patient's received adequate sedation, so we'll be checking his level of consciousness. Hello sir, can you hear me? Can you hear me sir? No response, so the patient is adequately sedated. Now we select the joules, which I have at a rate of 200. We're going to start charging the defibrillator, then we'll deliver the shock. Okay everyone, charging. Stand clear, shocking the patient, everyone stand clear. Shock delivered. Now we wait to see if there is a change in his QRS complexes and heart rate. As we can see here, it's fallen down to a regular sinus rhythm, heart rate falling, 109, now we've got 90. So now his heart rate is sitting around 80 with a nice steady sinus rhythm, so now I determine the patient is no longer cardiovascularly compromised. I've been dispatched to a 40-year-old male who has fallen from his roof, 6 meters from his roof onto a concrete driveway. He's landed on his occiput. He was water blasting his roof at the time and he slipped and fell. His neighbour saw this and called 111, but she couldn't offer any assistance because she was on a Zimmer frame. He has no previous medical history and is presenting with having an isolated injury to his occiput, an obvious boggy patch 6 centimeters in diameter. The patient is supine but posturing and extending, slightly restless and maybe combative with moaning and groaning. His vitals is he has a heart rate of 50, a blood pressure of 160/90, and a regular respirate of 12, a BGL of 7.6, and a temperature of 37 degrees. I have decided to give him a GCS of 6. I have decided to call for backup, and which for an R50. I have decided to call for backup for an RSI R50. It advised me that 10 minutes away, and the RSI officer wishes me to start RSI prep. So while we're waiting for the RSI to arrive, we're going to begin treating the patient's TBI. As you can see here, we've immobilised the neck to prevent further C-spine injury. We've also got an OPA and an LMA on standby in case we need any manual ventilations with the bag valve mask here. We've got 10 litres of oxygen flowing through the reservoir mask. We've also got the leads attached so we can observe the patient's vitals. And we've also got a bilateral IV set up here. We've got a saline administration set on standby if we want to administer any fluids. We also have some morphine here to sedate the patient should they become combative. Prior to drawing up the morphine, of course, I drug checked with my crew partner. So I've updated the incoming RSI of the most recent set of vitals, so now I'm going to proceed through the RSI checklist. So we've attached the nasal prongs without oxygen. We've pre-oxygenated using a reservoir mask at 10 liters a minute. We've attached the ECG and the MIBP and the SpO2. We've prepared the capnography over here. We've positioned the monitor so it can be seen by the RSI officer, with less space to the right so they can assemble their equipment. We've gained bilateral IV access. We've also prepared a running line of saline solution, drug checked as well to make sure it's okay to administer. We've positioned the patient for optimal airway control. We've got an ETT tube holder around with the strap undone into the patient's head. Ensure the suction is working. Excellent, it's working perfectly. We've prepared a manual ventilation bag with a PEEP valve attached, as we discussed. We'll obtain another set of vitals as well, so the RSI will have immediate knowledge when he arrives. And we'll obtain a final set of vitals to update the RSI officer for his arrival. The ICP may only attempt intubation maximum of 2 times, and then they'll have to revert back to using an OPA or an LMA. The ICP may require assistance using the burp technique, which is backwards, upwards, rightwards pressure. They'll also may need assistance with the bougie, which is used to find anatomical landmarks, in that they'll need you to feed the tube over the bougie. They'll also may use cricospherotomy, which is an incision in the skin over the cricoid membrane.